Hi, and welcome to Sientra's Tech News. This is our second reconstruction episode. So I'm very pleased to introduce our panel that we've brought together, experts in both autologous tissue transfer as well as tissue expander implant-based surgery, or even direct implant if the case is right. So let me just go around the horn and introduce the panel. First, out of Houston Methodist in Texas is Dr. Warren Ellsworth. Thank you, Warren, for being with us.
Happy to be here. Thanks, Blaine.
Great. And next, out of West Virginia is Dr. Tom McClellan. Interestingly, is the inventor of the AlloX2 Sientra expander with an integrated port for drainage. So thank you, Tom, for being on with us. Thank you for your innovation in the space.
Thank you, Blaine, for having me.
And next on our panel is a very busy surgeon in Pittsburgh, Pennsylvania, leading his plastic surgery team there in a community setting. Thanks for joining us, Dr. Dan Murariu.
Thank you for having me.
Great. And last but certainly not least, who recently took over the Chief of Plastics position at WashU is Dr. Justin Sachs, formerly of Johns Hopkins. Thank you so much, Justin, for being on with us and everything you've done in the space.
Blaine, thanks so much for having me on, and I'm really looking forward to interacting with this panel. It's going to be great.
Thank you all. And let's just start the discussion with that first option, to flap or not to flap. That is the question. What are your considerations? Let's start with you, Dan.
Pretty much all patients will have an option for a flap, whether it's autologous in the sense of a free flap or autologous and combined with an implant using the latissimus. I think all patients have that option. I do a lot of free flaps, so I prefer free flaps if I'm going to use autologous. But I do think the latissimus with an implant is also a good option in certain patients. What I look for in patients that I will do free flaps is, are they good surgical candidates for longer surgery? Meaning, do they have any comorbidities that would make it more difficult, such as if they're morbidly obese, if they have a blood clotting disorder. Otherwise, pretty much everybody's a candidate as long as they have an abdomen that has enough subcutaneous fat or thighs where I could also get tissue from there.
Great. That's great to lead us in. How about you, Warren?
Thanks, Blaine, and thanks, Dan. Agree with much of what you said. I let the patient drive the initial discussion. It's a lengthy, 1 hour visit, in all honesty. They've just found out they have cancer. It's an emotional time, and there's a lot of information to share with them. So we do an inventory of their current breast health, their current breast size, what their goals are, whether it's unilateral or bilateral. And then, of course, an exam sort of leads me down the road, whether they have an appropriate amount of soft tissue for perforator flap reconstruction. I do a lot of perforator flap reconstruction, deep flaps from the thighs, as well as implant reconstruction, and then hybrid models using both for particular cases. But the patient in my practice usually drives us toward which model is best for her. And of course, the additional part that's critical is her treatment. In other words, her adjuvant treatment needs of chemo, and most importantly in my hands is radiation. I'm still a believer that if a patient is going to be radiated, the best reconstruction for her is with autologous tissue. In my experience, implants long-term alone in a radiated chest wall are wrought with difficulty and problems. And so those are patients where I especially lead them towards autologous reconstruction.
Good points. How about you, Tom? What are your initial thoughts?
I agree. Since I've been in practice, I've done everything from trem flaps to deep flaps to now my practice is mostly tissue expander implant-based reconstruction in latissimus. I think is a good backup plan. I agree with Warren. Talking to these patients, most of them are in shock. Many of them have difficulty compartmentalizing the mastectomy part from the reconstruction part, and some people don't want reconstruction. They can't think past that initial blush. So I think the discussion of saving the skin envelope is just so important, whether that's autologous or just a tissue expander, until they can wrap their head around what they want to do or get them to a microsurgeon if they want microsurgery. It's a simple explanation of, here are your options. Do you want to get back to life quickly? Do you want to go through a longer hospital stay? And the trade-offs, there's no perfect surgery is basically what I tell them. It is a lesser of many evils. And so having that discussion, I think, is the most important part, to let them know their options, because many people have no idea what they want or what the options are. But the key is just to spend time with them and figure out what their goals are, because setting those goals, I feel, at the beginning is really key to success.
Great perspective. Justin, let's end off on the beginning with you.
So, great comments all around. I try to make it very simple and straightforward for the patient that, as Tom mentions, is sort of devastated that they have breast cancer or they have a genetic predisposition. So, they kind of walk into your office in a state of shock, because either they've come from the breast surgeon or they have a genetic diagnosis. So they know they're potentially going to lose their breast or have their breast, the shape of their breast change. So I just make it very simple to start. I kind of make things like an algorithm. So I say, if a woman's going to have a mastectomy, I say you have 4 options. I literally say 4 options. I say you can do nothing, you can go flat, you can have your own tissue. And I don't start talking about perforators and deeps and SIAs and apex flaps. I don't confuse people with language they don't understand. I just say we can take tissue from any part of your body and transfer it to your breast. That's number 2, autologous. I say use your own tissue. And I say words like skin and fat, because people understand that. Then I say 3, we can use implants. And I say, we can use saline or silicone. And sometimes I make a joke, in the future we'll have implants that connect to the internet and are fluorescent. I mean, just to get them, thinking about that this is, it's not the end of the world, because we will reconstruct the breast, we will cure my cancer. And then 4th, I talk about combining 2 and 3 together, your own tissue and implants. So I say 4 ways, and that's my consult, and that's my consult every time. So patients walk out of that room knowing that they have 4 different options. And then the question is, where do you begin there? I really try to get that cancer treated or that that genetic predisposition taken care of. So I lean always less towards immediate free flap reconstruction and more towards a staged approach with a tissue expander placement. And we can get into prepectoral and subpectoral after, but I really always lean, if a woman's going to have a mastectomy, in my practice, I always lean towards a tissue expander placement to set the stage for implant or their own tissue or a combination or nothing. Because, and just to the point about, what Warren said about treatment, patients might need radiation. So by preserving that skin envelope or getting them through chemotherapy, we don't burn any bridges. We give them a chance to think about things. And then you can go to implant or autologous. So that's my algorithm. That's my consult. And I do it the same way every time. I train the residents, the fellows, the PAs, the nurse practitioners, so that people, if I'm not even there, we create that culture of these are the options. Now, I'm not saying that's the right way to do it. I just like to give patients the same reliable information over and over again, because they're not really hearing you sometimes. All they're hearing is breast cancer and I'm going to lose my breast. So I try to make it, simple, straightforward. So that, that's my sort of 2 cents on how I open it up.
Yeah, no, I think these are all great points. And I think the shout out would go to this idea of truly understanding what the patient is and involving them in that choice process. And then I love what you said, Dr. Sachs, about keeping it in patient terms so they understand, and giving a kind of a regimented choice box to guide your conversations next. So let's talk about, maybe in the particular, you've decided that someone is a candidate for a flap. What is your preference of the flap and why? Just brief around the horn. Let's start with you, Warren.
If a patient's a candidate for a flap, she has the appropriate minimal comorbidities. I think my ideal donor site is using the abdomen for many reasons. I would say a deep flap is ideal for me because I have a lot of experience in it, so I'm just personally comfortable with it. I think it's ideal because it puts the scar in the most hidden position of any of the perforator flaps that I can do, or that the majority of plastic surgeons offer, because it's underneath the bikini line. I think the other benefit of perforator flaps from the abdomen, whether it's SIEA or deep flaps, is they're relatively predictable anatomy, and I can study them with preoperative CT arteriogram, which gives me basically a roadmap that speeds my dissection, and I have a predictable algorithm with how I take care of them postoperatively. And there's something really safe and comforting to both surgeon and honestly patient with reproducible results, with repetition in numbers and high volume. And so I love using the abdomen. It's a fun day for me and my team. I've become very comfortable and expeditious with choosing perforators and how to choose what and why. And that's a whole nother discussion, but that's the ideal case for me. And I will add, the one thing I've really been surprised about is that almost any woman in my practice that says, "Doc, I don't want implants, I want to use my own tissue," it doesn't really matter how petite they are. If they have had a baby before, I can pretty much do some sort of deep flap or stacked deep flaps to rebuild a breast. And I've been pleasantly surprised with that as I push the envelope.
You said you do stacked flaps. In general, are they usually immediate, delayed, and nipple sparing coverage, or keep the donor site skin?
Yeah, so we do nipple sparing mastectomy whenever feasible. I think that envelope is being pushed at a national, international level. And so no longer does the tumor have to be, 3 centimeters from the nipple. That's just, we do more aggressive nipple sparing mastectomies. I still don't like to do nipple sparing mastectomies in a patient who has a D or a double D and would prefer to have perkier, smaller breasts. I will stage those people with a lumpectomy and a WISE pattern, come back 6 months later and do nipple sparing mastectomies, but a little bit different than Justin's approach. I like immediate reconstruction as long as they're not getting radiated. If a patient has DCIS and local, non-invasive disease, and I'm quite positive that there's no lymph node involvement, then we'll do immediate reconstruction. Oftentimes, to make sure they don't have lymph node involvement, we'll stage a lymph node first and then do the mastectomies and immediate reconstruction, because I can always, or almost always, get a better looking result if I do it at the time. Now, if there's any signs of need for radiotherapy, then I'll delay it with a sort of a babysitter procedure, putting in a tissue expander, holding the skin envelope as much as possible, and following it up with a flap if that's what the patient chooses.
Sure, great. Okay, how about you, Dr. Sachs?
If a patient is choosing autologous tissue, the best thing is to discuss the different types of donor sites. And I always say, I show a picture of the places we can take tissue, and I talk about the back and the abdomen and the flanks and the thigh and the buttocks, and I go through the whole sort of just from A to Z of where we can take tissue and what the pros and cons of taking tissue from one part of the body to the next is. And, taking the tissue from the abdominal wall is definitely, is a more popular option for many patients, but not all patients have the tissue. Not all patients want to go through the decrease in core strength. So there's other options. And a lat flap and an implant is a great operation for that patient who doesn't want core strength to be cut or doesn't have the tissue. Thigh flaps are great for the woman who doesn't have the tissue, who doesn't want the scar across her abdomen, who wants a thigh lift. It just depends on sort of the patient. It's really important to, that's the conversation where things can, take a little bit more time, because you really have to be nuanced in what you do. There's a reason I just, I favor, to warn your comment, I just like controlling that skin envelope. I don't, do you do immediate nipple sparing free flaps?
Yes.
So, that's something that I think has to come with a large word of caution. So you might have a specific breast surgeon or technique that you do, but, to do an immediate free tissue transfer in a large breasted woman with nipple sparing, you potentially run the risk of nipple necrosis. In some patients, maybe in your patients, you don't have that risk just based on patient selection. But I think, for the majority of patients that I see across different geography and different BMI and different size of breasts, if you do an immediate free tissue transfer for nipple sparing, there could be some risk with nipple necrosis in the setting of the type of, just in the thickness or the thinness of the flap and the perfusion. So,
Totally agree. Yeah.
I try to mitigate the risks, and I also just try to control the skin envelope up front.
I think controlling the benefit of the tissue expander is controlling skin envelope, and the downside is perhaps another anesthetic that you put the patient under. And I'm still, like I said, I'm very much for avoiding radiating my flap. So if I'm going to do a flap, I really want to know that they're not going to need post-mastectomy radiation therapy. My one comment about the nipple-sparing mastectomy is, believe me, my flaps are not the thickest flaps, and I don't do nipple-sparing mastectomies or don't condone it really for very large-breasted women. But the flaps, I did bilateral nipple-sparing mastectomy and immediate deeps yesterday. The nipples looked okay on SPY. I know I'm coming back for fat grafting and a revision, so I buried the skin paddle underneath there. So in other words, she's going through 2 surgeries, just like all of, I would say 95% of us that do deep flaps or perforated flaps, they come back for some sort of revision most of the time. And at that point, I've got buried skin from the abdomen in case I get in trouble with the skin necrosis that does happen. But if it's not there, I simply de-ep it, do my fat grafting, and it's another option. So certainly not the only option. And believe me, Justin, I agree with a lot of what you're saying about controlling skin envelope. I just think for the occasional patient, immediate reconstruction is a great option.
Oh yeah, no, of course. But my only point was it's a great operation. I mean, if you could do an immediate free tissue transfer on nipple sparing, that's the best type of outcome for a patient who wants autologous, because it's potentially one operation. But I am concerned with the nipple aerial or perfusion. And I think if you did 100 or 200 of them on all different shapes and sizes, you might have a little bit higher rates of complications than you wouldn't. And that's all I'm saying, not to say.
The other point maybe is that if you had 100 or 200 of those cases spread across 5 different surgeons, 5 different teams, you might have a different risk factor for that than one person with the same team with a lot of experience and resources. But let's get to Dan really quick. Your thought overall, your favorite flap, and or at least what you find yourself doing most with your population.
Right. So I end up doing a lot of tissue expanders at the first stage. The one time that I will do immediate autologous would be in the setting of a BRCA patient that does not require nipple-sparing mastectomies. Otherwise, what I've noticed is, and I agree with Dr. Sachs, he mentioned earlier that we throw a lot of information at the patient, and they will sometimes change their mind throughout their journey, which will often take a year. Therefore, I prefer to do a tissue expander at the time of the mastectomy for several reasons. I've had several patients tell me, yes, they want autologous, but then a few months later, they realize they don't want to go through a long hospital stay. They just want to get in, get out, and then they go to implant. Or I've had patients that do want autologous, but all of a sudden they have radiation, and I would prefer to radiate a tissue expander than my flap. So tissue expander for me has been the first step after a mastectomy. And it also has become a logistics issue too. As I'm booking out several months in advance, I prefer to do a reconstruction of a mastectomy as soon as possible. Therefore, I do not want to delay somebody's cancer treatment just so we can have a full day for bilateral deeps or autologous reconstruction. Whereas I can easily figure out a way with our breast surgeons to perform the mastectomy and the reconstruction of tissue expanders, even if I already have several cases going on. So my preference is for tissue expanders, and then talk with the patient at 6 months later, either exchange for implants or perform autologous reconstruction. If they get radiation, then obviously that gets a little bit delayed. In terms of autologous, I do prefer the abdomen. I think most women do have enough excess fat in the abdomen that can reconstruct a breast, and most of them have enough for bilateral. Obviously, that's not always the case, and sometimes you have to do multiple flaps. Or sometimes I have done a combination of autologous with implant as well. But I do prefer the abdomen for reconstruction. I think it's a neat procedure from all standpoints. The residents and the fellows really like that operation. And what's also important for the surgical team is to have something that's done consistently over and over, and they're used to the procedure. Sometimes we may have nurses or scrub techs that don't routinely cover plastics come in, but sometimes they come from time to time, and they know what to expect, even they're not there every single operation. At least they've seen it in the past, rather than one day do autologous from the belly, then the next do it from the thighs or from the flanks. If the belly is not an option, then I will go to the thighs. I do have a preference for the pap, but first and foremost would be the abdomen for me.
And I would add one thing, just to the discussion. Dan sort of touched on it, which I think is so critical. If you're going to do that much microsurgery and a huge amount of microsurgery in your practice, just to make it livable, you really have to do what Dan highlights, which is do something consistent. And that's throughout, whether it's this similar flaps, it doesn't have to be the same flap, but a grouping of flaps that you're comfortable with, that your team is comfortable with, because it has to be livable too. You can't be there for 12 hours. I mean, if you're going to do 150 flaps a year, you need to be done at 2 to 3 so that you can have a life too. Otherwise, I think it's really not sustainable at a high volume level. And it's just, like Dan said, much more fun when you can make it livable and more efficient.
I think it's important to mention all the stuff you guys say is just wonderful. And the one thing I will mention is you guys are all in major academic centers, and I'm in solo private practice in a more rural area. I actually service 8 general surgeons, and from another community, about another 8 general surgeons to 1 plastic surgeon. So I have a high volume of breast reconstruction. And one of the things that I found is, I love, someone mentioned, I think it was Dr. Sachs mentioned, controlling the skin envelope. I love that. If they're going to get radiation, this is a very fluid environment. You don't know what your flaps are going to be like. You don't know what the lymph node's going to say, whether they're going to get radiation. You have some understanding, but it is a fluid situation. And then there's logistics with how do you operate with all these people to get that immediate reconstruction. And then Dr. Sachs, I also agree with, don't burn any bridges. So for me, the tissue expander is a big workhorse because it stabilizes the skin envelope. It doesn't burn any bridges, so that I can send them to Pittsburgh for microsurgery reconstruction, since I don't do that anymore. It's great to meet Dan, because I actually will refer Dan a lot of patients. I have a lot of people that I would like to do micro on, that since I don't do it anymore as I've gotten older, that I don't have a good reliable locally. So it's great to meet you, Dan. I actually looked you up, and your reviews are excellent, and I'd be happy to send you patients. But I really believe controlling the tissue envelope, giving the patient an option, is really important, particularly for the solo surgeon. It's pretty easy to do, and it certainly helps the patient a lot.
Great. So let's stick with you then, Tom. Let's transition a little bit. So those patients that you're either prepping for a flap with a delay with a tissue expander, or your plan is tissue expander to implant. Let's talk about the AlloX2 technology, what it does in those situations. And first, from you, Tom, you came up with it. It's obviously a long path for anyone to come up with something that unique, but also, geniusly obvious of the need, and then actually bring it to market. So thank you first for doing that. But what was the original push to make you take that leap?
The push was I have complications. Seroma, getting the allograft to integrate quickly. What was the milieu that's around the tissue expander? Did that lead to infection? And I had problems. And that's what led to me thinking about it, is how can I access prosthetic space without an ultrasound in the office, very easy and simply? That's one. Two, at the early stages of allograft reconstruction, we had red breast. I don't know whether it's the way they process the allograft or not, but you would get this redness around the breast, and you didn't know if it was a reaction, whether it was a seroma, or whether it was a true infection. And so it gives you the ability to sample that fluid. And then finally, once someone got an infection, if it wasn't raging and it wasn't cellulitis and it was paraprosthetic, I thought, could we treat this by injecting a bactericidal antibiotic in the paraprosthetic space? And so I figured a drain would solve many of those problems.
I think that's tremendous. We'll chime in here just because I think, Tom, it's disruptive technology. It really is. And it's amazing because it's exactly what most of us who do a lot of breast reconstruction need, which is access to the periprosthetic space. That's the game changer in breast reconstruction. And everyone who does tissue expander-based breast reconstruction, or even direct to implant, but most commonly with tissue expanders, deals with seroma. Whether or not you use support of a scaffold, but often the scaffold adds that risk. And so I think accessing that space, draining that space, treating that space is really kind of remarkable and disruptive in nature, and really helpful to the practicing plastic surgeon with a busy practice like yours, where you don't have time to send them down to a breast center or deal with all these issues. If you can handle it quickly and efficiently in your office, or have a PA handle it without you there,
Right.
It's pretty remarkable.
I totally agree. The AlloX is amazing from that standpoint. You have that access to the periprosthetic area. Obviously, you know, if a patient is going to get radiated, you know that you want to expand them as much as you can, as soon as possible. You have about 4 weeks for the ADM to integrate. So I have a lady that I did her tissue expander reconstruction 4 weeks ago, bilateral, and she's getting the planning actually today. So yesterday when I saw her in clinic for the last fill, I noticed that she may have seroma. So what I did, I just aspirated it. I did my fill, but I was able to aspirate it, and it was easy. I didn't have to send the patient to the breast center to get an ultrasound, and afterwards to get to see if they could drain it. I did it myself. I could tell a difference afterwards. So I really like the technology. It's simple in the sense that you're just like, wow, okay, why didn't I think of that? But it's great, and it does make your life a lot easier. And for the patient as well, you know, you tell them, I think you have a little bit of fluid, I will take care of it right now. And that's what I was able to do actually yesterday in clinic. So I'm very impressed with the tissue expander technology.
Dr. Sachs, I know somewhat of a recent user of AlloX2, but at 2 institutions now. What's your experience been with, and what does it enable you?
In an organic situation, you're gonna have a bacterial overgrowth at some point. So first principles, let's get that fluid out. So either you drain it with normal drains, or you drain it with a device that you can, drain fluid out through a secondary port. I have no disclosures with Sientra. I don't get paid. I don't I don't stock. I just am somebody who, other disclosure, I started a biotech at Johns Hopkins called LifeSprout. So I know what it's like to create intellectual property and try to bring something to market. So when you think about, first principles in breast reconstruction is this, as Dr. McClellan mentioned, the reason why he invented this is because of his complications. Like if he wasn't having problems with it, he wouldn't have thought about a way to, innovate around it. So the problem with tissue expander breast reconstruction is that we have a high rate of infections and seromas and we have problems with it. So, the idea to be able to take the fluid out through a port that you control as the surgeon and not with somebody else, like you literally control it at the point of care. I mean, just to tell a story, and this is great. I had I won't say which institution, I won't say which residence, but I was literally called to the emergency room to see a patient that had a tissue expander seroma forming that was tenting the tissue, so it looked hyperemic. And the call was infected tissue expander. The patient was NPO, and the operating room was calling for the patient. And I looked at my book, and I realized that this was an AlloX. And so I said, let me come down there. And I had in my pocket the magnet. And so I said, I actually called like 4 or 5 residents around. I said, come down and watch this. And they said, what are you going to do? I go, watch this. And so I just, played around with the magnet. I had to figure out, which was aspirated and which was, infused. Because the one that I was using wasn't clear, right? And then all of a sudden I pulled out this beautiful yellow seroma, and all of a sudden the breast went flat. It was yellow. It was clear. It was serous fluid, so it was yellow. It wasn't purulent. It was serous.
Right.
So my leading suspicion was, okay, maybe it's just a seroma that wasn't drained. Whatever it was, put the patient on. I said, you can eat. She's like, what? I'm like, you can eat and go home. And everybody was like, what? I'm like, yeah, go eat, go home. and I put them on oral antibiotics, and the culture grew out nothing. And what I did was prevent one patient of mine from going to the operating room unnecessarily. And that was, for me, that was a tipping point, because I had tried to get it for a while at the institution I was at. And, and then once we got it, I started using it. And for me, it doesn't take N of 1,000 to realize that you have something that's, it really is an innovation. It's not an improvement. It's an innovation in the way you sort of can manage the envelope and the tissue expander. So I don't know, those are my early thoughts on this. Now, to be very fair and balanced, I will compare, my last 100 tissue expanders that don't have that integrated port to my next 100 that do, and then we'll go apples to oranges and say, let's do the challenge and see what were the complications, what were the stromas, and then that's the kind of thing that will really sort of say this is a game changer or not.
The one thing that I have been doing that I don't know if you guys do it or not, is when I insufflate the tissue expander in the first 3 weeks after surgery. Let's say the drains are out and I'm starting my first insufflation. I'll access the drain. You get out a surprising amount of fluid. And then they come back in a week later or 10 days later and I'll insufflate them again. I'll also access the drain and they'll get out a little bit more fluid. And I don't know the importance of chasing out that fluid as you go up, but I do think this is anecdotal and I don't want to talk out of turn, but knock on wood, I feel like my infection rate has gone down or my redness rate has gone down by eliminating the fluid that's percolating in there.
Oh,
what do you guys think about that?
And Tom, remember, you're going to have patients, especially in your practice, where you're seeing a lot of mastectomies and tissue expander that you're not flapping doing implants. That fluid's going to get infected during chemotherapy or some kind of like UTI or you're doing them such a service by cleaning that out, getting that fluid gone.
How about just from a wound healing perspective, maybe Dan comments, just the idea that even if you couldn't have seen 10, 20 cc's before, that 20 cc's is in between ADM and tissue. So it's definitely not helping healing if you want true apposition and tension, just like a skin graft. Dan, are you aspirating serially or every time you see the patient, or are you just keeping it for that situation where the closed suction drains are out and you now have a seroma?
Yeah, I've been thinking about this. So far, it's always been if I need to. I haven't been doing it every time I do an expansion. I'll see if I get fluid out. I had been thinking about that. I have the access, so it's not difficult to do at the same time. Aspirate any fluid that may be hanging around there. Again, I like to expand rapidly. So I actually expand first visit at 1 week after surgery. At the time of surgery, I like to fill the tissue expander up to 50%. And then I like to expand to what I want to achieve within the first 4 weeks if I can. One, because if they're going to get radiation, usually it's going to be at 4 weeks. So you need to expand before they do their radiation planning. And two, there have been studies showing that the ADM becomes incorporated by week 4. So I want to be expanded by week 4. So I will go aggressive on the expansion. And I think it's important to, if you incorporate the ADM, you're going to have less fluid production. So there's going to be less seroma. So having that access port where you can aspirate any fluid and allowing the tissue expander, putting pressure directly on the ADM onto your skin flaps, I think that will help integrate the ADM faster. So I'm a proponent of fast expansion. I don't know what the other panelists think about that.
Yeah, I think it's important. I think the critical thing, it's just like a skin graft, right? I mean, you need apposition and you need to prevent shearing force and you need to prevent seroma. So I love draining the Allo-X and keeping it as dry as possible, just like Tom alluded to, because I think it makes a huge difference. The other cool thing that you can do, and this was we published this as part of the series, is treat the periprosthetic space, like Dr. McClellan alluded to as well. I had a patient early on, years ago now, that had an MRSA, an MSSA infection in the periprosthetic space. Tissue expander Allo-X aspirated it, cultured it, grew as an outpatient. I had her on multiple antibiotics, just like I always do. I use Cipro and minocycline because it covers everything until I know what's going on. And then I got dilute vancomycin, which I'm assuming is, I think is off-label, and irrigated the periprosthetic space and salvaged a tissue expander that historically would be very likely lost. And I think it sounds like not a big deal to lose a tissue expander, but what you have to remind yourself as a surgeon going through this, it is a freaking huge deal to you, your operative schedule, and most importantly to that patient, because all of a sudden when you get especially a gram-negative infection, but even gram-positive infections that progress too much and you go to the OR and it's just murky in there, you're trying to figure out if you're going to be able to switch it out for a new tissue expander or not. And let's say you can't, and then the patient's stuck for many months with a flat chest, and it's really hard for these women in a situation that's honestly already hard enough. So I think if you can salvage it and get the fluid out, and then perhaps even treat it really quickly, it's a huge benefit to that patient. And again, anecdotal, like Tom said, but I've treated a couple patients with periprosthetic. Both of them have made it. The one with the longest follow-up is now 2 years. So that's without any capsular contracture associated with long-term biofilm that I could think of. So small data, anecdotal, but really useful.
I think a lot of the stuff you guys brought up is worthy of study, especially this protocol of how aggressively or ambitiously do you use the AlloX2 once you've decided to put it in there. So you guys, thank you so much. I think that we've had an excellent discussion here, a lot to learn about both autologous and tissue expander-based reconstruction. Final thoughts as we go around the horn. You're starting this patient journey with the patient. What's the most important part to identify with them on that first visit to set the stage for your plan? Tom, let's go back to you, the inventor.
I just absolutely love breast cancer reconstruction. I love the patients. Being honest with them about what success is and what's possible, not burning bridges, and really choosing the right surgery for each patient. I really love this, and I love, I'm in solo private practice. You guys all have residents, and this has been a lot of fun for me. I love being honest with patients and trying to provide the best care for them and having the best discussion. I like Dr. Sachs's 4 technique. That's pretty much what I do, and is not as simple a form, but I think that's pretty much it. And thank you for allowing me to participate, Blaine.
Oh yeah, it's a pleasure having you. Thank you again for your innovations in the space. Dan, final thoughts?
I obviously agree with the panelists. Doing breast reconstruction is absolutely rewarding. And the patient comes in, it's not only a cancer diagnosis that you have to take care of, but it's also an aesthetic one. So you have to make the patient feel comfortable. You have to take your time. So usually it's a 2-visit process for me before we do the first operation. More recently, and coincidentally with the coronavirus, I've been only seeing the patient one time because we've been getting the patient in faster. And I think it's important to tell the patient, okay, well, we're going to get you in as soon as we can, which is usually within 2 weeks of me seeing that patient. Presumably they would have seen the breast surgeon. Sometimes we see them at the same time, in the same day. But we'll get them in quickly. We're not going to delay the cancer operation. I always tell them it's usually going to be at least 2 surgeries. Most likely there'll be a 3rd or a 4th just to get the symmetry better, just to get the aesthetics better. The first stage will be a tissue expander because we want to get the mastectomy done as fast as possible. We want her to have initial reconstruction to keep the skin envelope that we can achieve with the tissue expander. And for unilaterals, we let the patients go home the same day. For bilaterals, we keep them overnight. But it's a journey that we share with the patient. And what I try to convey to them is that although there will be several stages, the first stage will be the tissue expander. We'll get you in quickly. Once we get the cancer out, then we'll have time to plan for our final reconstruction so they don't feel stressed at all the information we throw at them to what option they have to choose right then and there, because we do throw a lot of information at them.
Great. Thanks, Dan. And Dr. Ellsworth, final thoughts on starting the journey?
Yeah, I think the goal of the first meeting is really to do exactly what Tom alluded to, matching the right procedure to the right patient. That's the critical, I would say, surgeon goal, but equally important, if not more important early on, is to give a woman hope. She's just been diagnosed with cancer. She's dealing, and I'm thinking of the 43-year-old I just saw in clinic, mother of two, single mother of two, and she's dealing with her mortality, worried about her kids and her family, and then she hears that her femininity is going to be removed. So I think we have the amazing ability to offer hope to these women, and that is such a privilege. And I can't overemphasize how important that is, I think, to so many women's lives, and really to the lives of the family members. So, hope of rebuilding what's lost and taken by cancer, giving them confidence and femininity, and really a future. There's going to be scars, but giving them options and hope means the world to them at that scary, scary moment. So I think that's just so important.
As Dr. McClellan said, breast reconstruction is just such a wonderful part of medicine that we're able to take part of, because, we take patients that have a diagnosis that, changes their lives, and we can be part of the process to, be along as they get cured, and then be along to help restore their, their femininity and the way they look, and improve the way they feel about themselves. So, I always stress that this is an operation, first and foremost, to cure your cancer or change your genetic destiny. And then our role is to really help you feel as natural as you did before, and to be balanced and symmetrical. And I always say, when I go 6 to 9 months from now, or a year from now, when all is said and done, you're going to be hopefully back to where you were. Things will change. And I think the thing about being honest and talking about the complications that can happen, and the successes and the failures that can happen. But I think if you are honest with the patients, and you are transparent, and you give them hope, it's some of the best, moments of being a plastic and reconstructive surgeon.
Great. Thank you guys so much. Innovation, patient selection, hope. These have been great topics. I hope you guys will join us for panels in the future. For those of you watching, now's a great time to get in touch with your Sientra folks. You can reach me at Sientra Education Forum at sientra.com, and look forward to future discussions with all of you. Thanks, guys.